So, good evening. Today is March the 30th, 2022, and it is 6:42 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. The first item of business will be public communication. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 3:30 p.m. today. Yesenia, did anyone register to make comments at the board meeting?
And just to clarify, while we're waiting for her to respond, it's 5:42, not 6:42. Sorry.
Well, that's good. It gives me an extra hour. Thank you. I don't have my full screen, so I don't know if she's...
Sure, if you'll just pause
Oh,
just a moment
Manager
while we
Valdez.
reconnect with Yesenia. We were advised prior to, we do have some individuals.
Hi, can you hear me? Can you
Yes,
hear
I can.
This is
I can
Yesenia.
barely hear you, but I can hear you.
Okay. Okay, sorry about that. Yes, we have 6 people signed up for public communication.
Okay. Would you please read the rules and then actually call them up?
Yes. So when called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. At this time, I will call upon our first speaker, Manager Cynthia Valadez, followed by Julie Hawley.
Manager Valadez? You're on mute. I see your mouth moving, but I don't hear anything. No, don't hear you. Now you're muted. So if you just...
I'm sorry.
Now,
Can you hear me now?
yes. Yes, we can hear you.
Oh, I'm going to turn off my phone. I think that's it. Because I was on the phone earlier. Are we okay now?
You're better now. You hung up the phone, right?
I hung up the phone. Can you hear me? Because I can barely hear you. Hold on, please.
We can hear you. It's not very loud. Can you not hear us?
No, let me turn this up. Let me see if I can turn up the sound.
You're sounding a lot better to us.
There?
Yes.
Okay. Now, thank you. Thank you for allowing me to speak today. Basically, what this is in regards to is item number 4, which I believe is a discussion with respect to Zaragoza. I had a meeting with John and Alan and Stephanie, and Brianna was present on Monday morning. And I'm calling with respect to the comments that were made by them and the couple of sheets that I saw, which were basically talking about the need for additional maybe primary and specialty service providers, and that was one of the reasons they were thinking about getting our Rosewood Zaragoza clinic up and going again. So in reflecting on that, what was a concern to me, because I was one of those people that said we should not close Zaragoza, what I wanted was sufficient data that showed that we need to have an additional clinic or clinics created, built, brick and mortar facilities, and with additional specialists and contractors with whom we would pay to provide those services to our patients. I just wanted to know whether or not the sufficient outreach had been conducted by Central Health and or community care, whoever is responsible for doing that for us. I wanted to know what our medical team is telling us and community care as to whether or not there is a sufficient population in order to support the Zaragoza clinic. If they're going to be sending people there just from the neighborhood or from all parts of Travis County, that's important for us to know, because we know previously they had said that there was no need for Zaragoza in addition to the structural issues and the new roof that it needed. So that's I guess the first concern that I have is just making sure that we have that. A second is in searching for additional specialists to contract with that would provide services for us. I was asking whether they had conducted a survey of existing specialists in Travis County or this area to know whether or not there was something that we could do with them so that we wouldn't have to necessarily build brick and mortar facilities, but rather contract with them and pay them their charge or increased charge so that they would accept our patients and that we wouldn't have a backlog. If we have a backlog, then what are the specialties that the backlogs are in, and who is not providing the services to us? Is it a contractual issue? I didn't know whether it might be between an entity that we already contract with, or whether there are other entities such as the University of Texas Medical School that should be providing those services. And since we hadn't received any information with respect to the $35 million that we're giving them, I was hoping that we would be justified in asking how they're spending that money. In addition, I'd like to know whether or not UT, Central Health, Community Care, Sendero, and whomever else could work together to look at the overall design or need for facilities, provision of services, hiring of doctors, blah, blah, blah. And what do we need to do in order to make that more amenable to our patient, to us as institutions and for our patients? Does that mean that should we look at maybe giving community care and our contractors more money, not just what the reimbursement rate is from the state, but more money so that they would be amenable?
Manager Valadez, you'll need to wrap up.
Okay, to providing those services. Anyway, with respect to, I did send you all a copy of my comments. I'd like for them to be reviewed. I'd like to have answers to that, and hope and pray that we can act on data-based research and information that is being provided to us by those that are asking for us to spend millions of dollars on the additional asks. Thank you very much. And
thank you, Manager Valadez. We appreciate that. And we will cover some of these items under agenda item number 4. Yersinia? I see we have somebody whose video is on, but you can speak. I don't know. You
Sure.
can
This
speak.
is
There
this
you
is Julie Holly. I was next on public comment, I believe. So
go. Great.
Joe, I think we'll time it from here in the room.
Okay.
Watch the time.
Thank you.
Cindy comes back online. Thank you.
thank
Go
you,
ahead.
Chair Bell. Thank you, Chair Bell and Board of Managers. My name is Julie Holly, and I'm here representing Ascension Seton. I appreciate the opportunity to be here tonight and provide public comment on the agenda item number 1 regarding the FY22 Travis Local Provider Participation Fund proposed rate amendment. And my understanding is that the current recommendation is a rate of 2.36%. Due to the many months of discussions going on between CMS and HHSC, lawsuits and court rulings, and with CMS's approval of these new directed payment programs just last Friday, March 25th, we're all under a very short time frame to ensure that all the providers have access to this funding. Ascension believes it's in the best interest of the community to set the rate at 4.04% now versus the proposed rate, because we believe that lower rate will then require an additional rate hearing and another rate amendment next month. There's already a very likely potential that there could be another additional rate hearing later this summer due to the timing of these programs and the various funding needs. And we recognize that setting several different rates during a short time frame is cumbersome to the central health staff, and we would like to minimize that as much as possible. Lastly, while we do believe that the 4.04% is the appropriate rate, our first priority is to secure funding to support the services to the poor and vulnerable. With that said, if the lower rate of 2.36% is approved by the Central Health Board of Managers, we acknowledge and respect that decision. But again, we believe there will be a likely need for future rate amendments in the next month and perhaps later this summer. Thank you for the opportunity to speak on this issue. We greatly appreciate the work done by the Central Health staff, and as in particular, Katie Coburn, so thanks for her time. And just again, we want to express our continued shared commitment to the Central Health Board of Managers to serve the individuals that are experiencing poverty in Travis County. Thank you for your time.
Thank you very much, Ms. Holly. We really appreciate your testimony, and definitely will give that consideration as we deliberate over agenda item 1. Thank you.
Hello, can you hear me?
Yes, we can.
Okay, perfect. Sorry about that. Some technical difficulties. Up next, we have Bill Galinsky with Baylor Scott & White.
Good afternoon, Chairman Bell and Board of Managers. My name is Bill Galinsky, and I'm here representing Baylor Scott & White Health, and also speaking on agenda item number 1. We appreciate the opportunity to be here tonight and provide public comment. Baylor Scott & White would have supported a 4.04% rate assessment, as Ms. Holly mentioned, to ensure supplemental funding is provided to continue our shared commitment to the poor and vulnerable. Due to many months of discussions, for those of you who aren't aware, negotiations have been going on between Health and Human Services Commission of Texas and CMS for several months now, and there's been lawsuits and court rulings, and CMS, as Julie said, finally made approval of these programs on Friday, March 25th. And so everybody's operating on a very short time frame to access the funding. Like I said, well, we believe it would have been in the best interest of the communities we serve to set the higher 4.04% rate now, as it might have avoided additional rate amendments in the coming months and the likelihood of another potential rate hearing later in the summer. We recognize setting several rates during a short period of time is burdensome on the central health staff, and would have hoped to minimize that as much as possible. Lastly, if the 2.36 rate is approved, as is being recommended by central health staff, we acknowledge that decision, we respect that decision. We'll work with central health staff, including and especially Katie Coburn, to ensure that the necessary funds are available. Thank you for the opportunity to speak on this issue. We greatly appreciate the work done by the central health staff and by the Board of Managers in this process, and offer our shared commitment to those groups to serve the individuals who require care that they do not have the ability to pay for in Travis County. So thank you.
Thank you, Mr. Galinsky. We appreciate those comments. And again, we will give them due consideration as we deliberate over agenda item number 1. Yersinia?
Yes, thank you. Up next, we have Eli Cortez with Texas Harm Reduction Alliance.
Hello, everyone. How's it going? Good afternoon. My name is Eli Cortez. I'm with Texas Harm Reduction Alliance. I'd like to thank the managers today for your time and consideration. We are a harm reduction organization that operates a drop-in center and a street outreach team here in Austin, Texas, and Travis County. Part of our work on the ground has been around supporting people who use drugs and using safely and making sure that they have access to things that will improve their quality of life, one of which is medications for opioid use disorder. Now, one of these medications is methadone. And we've heard that Central Health is in the talks currently to add methadone to coverage for MAP. Currently, MAP covers buprenorphine, which is another medication, which is also more expensive and less regulated than methadone, but it doesn't cover methadone. Methadone is affordable. It's only about $4,500 a year to treat someone, whereas when someone is admitted to an emergency room for a non-fatal opioid poisoning, that visit is about $93,000. Currently, Travis County has 2 methadone clinic offerings. There's a public one run by Integral Care that is currently at capacity and only is admitting people as one person leaves. It's like 1 by 1. And the private provider, Community Medical Services, has a wait list of, last time I heard it was about 100 people, 90% of which, 100 people that can't afford treatment for methadone, but 90% of which qualify for MAP. So we're really in an urgent moment right now. Travis County is seeing these huge risings in the number of opioid poisonings that are happening here. Even earlier this month, there was a 24-hour window where 12 people were admitted to the hospital and 2 people died in one day. So this is really an urgent matter. These conversations about coverage are really important to us for our team at Texas Harm Reduction Alliance, and we're watching today. And we'd really like to hear from the board today, really, like, what is the timeline around adding methadone to MAP coverage? How much longer are we talking? Is it in motion? Because this isn't something that we can really afford to wait on. And I'd really like to take the time to really hear from y'all today, like where y'all stand on that, how far it's moving, and how we can really make this a public conversation, because our folks on the ground, they can't afford to wait anymore. But I really appreciate your time, and I look forward to hearing from you all and your responses. So thank you.
Thank you very much, Mr. Cortez. I appreciate your comments. As you may or may not know, we are limited to talk about those issues that are on the agenda. And so, but I'm sure that if you reach out to any of our Central Health staff, they would be more than willing to have a discussion with you regarding the very eloquent issues that you made us aware of. Yersinia?
Thank you. Up next, we have Kate Graziani with Texas Harm Reduction Alliance. Kate Graziani, are you on this call? Let me see. I'll move on to the next one. If you're having technical difficulties, Kate Graziani. Up next, we have Ricardo Garay with Dell Medical School.
Good afternoon, y'all. Chair, board, thank you so much for taking my comment. Let me also start by saying it was really great to be able to see some of you at the Saturday event at the Horsley Bend, breaking ground. My name is Ricardo Garay. I'm a program manager for community engagement and health equity at the Dell Medical School. And I was born and raised in Honduras, where I was also exposed to community health workers, also known as promotoras de salud. And so I want to be able to share kind of a snapshot of some of the work that's been happening in this area at the Dell Medical School. We have, in the past year, a couple of years, hired 6 community health workers, 7 including myself, working in different areas. We hired Richard Johnson that is doing some work with the mobile outreach team with our neighbors that are experiencing homelessness. We have hired Brenda Garza to work with medical transitions coming out of the Del Seton Hospital, initially focusing on the Latinx population there around COVID, but now have really expanded the scope with those transitions. We have also hired Josh Collier, working at the Lone Star Circle of Care Clinic in the Runberg area to provide needs assessments and referrals. And we have also hired Tanya Degtoff, Jenzi Zane, and Chris Mora to work around vaccinations. And so they have been going to different mobile sites and partnering up with the nursing school and the BAMOS initiative that the nursing school has led to establish trust and get folks in the community vaccinated. Along those lines, they have also been able to provide referrals to different resources. They've helped people fill out rental assistance applications. They've done food deliveries. They've done a number of things. So as community health workers, we're always trying to find a best way to serve our patients. And that can look very, very different. And we are trying to be very intentional about this. We have all these community health workers are certified by the state of Texas. We are constantly receiving training on different topics. I myself am a board member at the National Association of Community Health Workers and also a board member of the Texas Association of Community Health Workers, which allow me to have a platform to hear and see best practices, again, both at the national level and the state level. I'm trying to bring in these resources to my team here and to share those with other groups in Central Texas that are working with community health workers. Some of these trainings also include mental health first aid, health equity trainings, motivational interviewing, which is something we use a lot as community health workers, and trauma-informed care as examples of some of the training that the community health workers receive. The staff, the team is bilingual. Gen Z actually is speaks Mandarin and English. The rest of us speaks Spanish, English and Spanish. We have a lot of lived-in experience, and we're also coordinating work with other community health worker teams in the Central Texas area. So we've had conversations with Central Health and the team with Community Care and People's Community Clinic and so many other community health worker teams that are doing this work. I think one of the things that has been also very intentional in our work is that the research and evaluation of our work. And so we're constantly looking for funding to continue doing this work.
You have 30 seconds left.
Thank you so much. I'm about to finish here. And the other thing too is that we have been very intentional about embedding these community health workers in other places, leadership places. For example, the CAN Community Council, the Central Health Community Community Champions as well, the Caritas Board of Directors, and the AISD Up Close Academy. So I'll finish with saying that this is only work that we have just started. We are trying to build a community health worker hub at Population Health to better coordinate all this work happening with community health workers. Thank you very much. It's good to see you.
Thank you very much for your comments. You are, and your group is doing wonderful work that we appreciate, especially as it involves the population that we serve. And so thank you very much. And Yersinia?
Yes, thank you. I'm going to call upon Kate Graziani one more time. They are with the Texas Harm Reduction Alliance. So it might have been that Eli went for that group already. So one last call for Kate Graziani. If not, that concludes this portion of public communication.
Okay. Well, we thank Ms. Graziani for taking the time, and we appreciate all of the comments we received from the public today. Thank you, Yesenia.
Thank you.
We will now proceed to the consent agenda. Consent agenda item 1, approve the minutes of the Central Health Board of Managers February 23rd, 2022 meeting. And consent agenda item 2, receive the quarterly investment report and ratify Central Health investments for February 2022. Do I have a motion to approve the consent agenda?
So moved. So moved. She did it.
Thank you, Manager Zuniga. Do I have a second?
I'll second.
Thank you, Manager Brinson. I have a motion by Manager Zuniga. I have a second by Manager Brinson. Any further discussion? Hearing none. All in favor?
Aye.
Any opposed? Any abstaining? The consent agenda has been approved. We will now proceed to the regular agenda. Members, I will be taking up agenda items in the following order. Agenda item number 1, 2, 3, 5, 6, and 4. Also, members, it's really important that you let me know if there's a time certain that you need to leave so that we can manage the quorum appropriately. Okay, that being said, as we have done for our last several meetings.
Sorry, I believe Manager Musaitis has a question.
Oh, I'm sorry, Manager Musaitis.
Oh, I may have, you maybe speak on that behalf if we can limit discussions.
Say that again, I'm sorry.
You may speaking on what I wanted to address, limiting discussion.
Yes, it's coming up.
Thank you.
Okay. And I will let you make the motion. As we have done in the last several meetings, we will entertain a motion to limit debate on the board meeting, for the board meeting, and staff will be asked to keep their presentations within a preset time limit. Also, members, please speak for permission from the chair before speaking to ensure that microphones are activated. At this time, I will entertain a motion from Manager Musaitis to limit debate for all items in the regular agenda for our meeting this evening. Manager Musaitis?
Chair, I make the motion to limit discussion to all items. Are we stating how many minutes? 3 minutes? I think that's what we did in the past.
3 minutes per member per item.
Correct. Thank you.
Second.
And Manager Valadez?
Can you hear me?
Yes, I can.
Oh, thank you. No, I'll second that. There's no problem, except that don't forget that some of us are on a screen. So that's all. Just
I appreciate
it. Thank you.
I appreciate that. I have a motion from Manager Musaitis. I have a second from Manager Valadez. Any further discussion? Manager Jones.
Just a quick question on the enforcement of the recommendation that Manager Musaitis just put forth. Are we asking, is this for staff or is this for board members?
It's for board members.
Okay, so my question is enforcing, how we're going to be able to enforce it? Should we extend it?
It will be timed, Manager Jones, and the timer will let me know, Perla will let me know when the time is up, and I will let the manager who is speaking know that they need to wrap up.
Well, either we have a time or not. So is it possible the mics could be cut off at that time or some kind of method to
Well,
ensure?
I
Because
wish I had that control of turning that mic off, but I
it's not
don't
that I
have
want to
that.
hear, it's just the fact that if we have a time frame, we have to stick with it. And so I just want to make sure that once that is done, that is enforced.
I totally agree with you. Thank
Whether
you.
it's me or anyone else.
I totally agree. Manager Greenberg.
I do understand. I know Perla will be timing it, but I think it is incumbent upon all of us as board members to help Perla.
Thank you, Manager Greenberg. Okay, no further discussion?
Excuse me.
Yeah. Oh, Manager Valadez, sorry.
Case in point. But this is what happens sometimes when not everybody can see the screen, or when you can't always see the screen. However, with respect to the time limitations, I also like to I guess support the fact that also we need to hear from staff to make sure that we have a thorough understanding of what the issue is, especially if it may be a more complicated or important issue. And as such, however, I would rather take time away from staff than take time away from our board to have that discussion, since we're the ones that are the policymakers. So I just want everybody to be cognizant of that.
Thank you, Manager Valadez. We do advise staff to take enough time to be able to outline the issues for us, and then we can actually have question and answer sessions. We just would like for everyone to adhere to the time limit and be as concise as possible. Any further discussion? And I will try to look at the screen. The screen is tiny in front of me, so it's not like I can really see your hand waving as when I had the big screen that was in front of me. It was hard to miss. So I guess maybe I'm just a fan of big screen TVs. But anyway, we will do our best to make sure that I recognize the folks virtually. Any further discussion? All in favor? Any opposed? And any abstaining? Motion carries. Thank you very much. Agenda item number 1. Discuss and take appropriate action on the proposed amended mandatory payment rate to be assessed on institutional healthcare providers during fiscal year 2022 under the Local Healthcare Provider Participation Program, parentheses LPPF, in Travis County as required by Texas Health and Safety Code section 298E.151. Katie Coburn will be presenting.
Thank you, Chair. Yes, I'm Katie Coburn. I'm on the finance team at Central Health, and I am going to be discussing this evening a proposed mandatory payment rate amendment to our FY22 LPPF rate that we set in January. So just a reminder as we get started, what the LPPF mandatory payment rate does and what Central Health's role in that is. It is a uniform percentage. It's set as a uniform percentage of net patient revenue of all Travis County inpatient hospitals. The rate is set by the Board of Managers, and Central Health, as the LPPF administrator, collects those funds and holds them in a fiduciary capacity, using them for legislatively defined purposes of intergovernmental transfers that support federal supplemental payments. There are 2 supplemental payment programs, DISH and DSRIP, which our enabling legislation prohibits us for using these funds for, but otherwise, programs like uncompensated care and Medicaid directed payment programs are eligible to be supported through an LPPF. Central Health works with hospital representatives and collaborates with them on uses of the funds. And again, you all set a rate in January of 0.82%, much lower than we typically do. That was due to a lot of the uncertainty that does exist around the supplemental payment program approvals right now. Brown, the next slide, please. Did it flip for you all? It didn't flip for me.
Yes, we can see it.
Okay, great. So just a little bit about that background. I know that you all know that as our 1115 Medicaid waiver program is coming to an end, CMS and Texas have been in protracted negotiations over months over Texas's proposed Medicaid supplemental funding programs. They, as part of this transition, they have proposed 5 different Medicaid directed payments Those are provider-specific programs that use local funds and IGTs to enhance Medicaid payment rates. 2 of those were approved recently. The final 3, were approved on March 25th, so last Friday. That decision was compelled by a federal judge who required CMS to make that decision one way or the other, and CMS did approve the funding. The CHIRP program, Comprehensive Hospital Increased Reimbursement Program, is the one most relevant to us. And statewide, the pool is $4.7 billion. So it is a large amount of funding that will be flowing to those providers if all continues to go well. In their approval, CMS did indicate that they reserve the right to continue reviewing the permissibility of the non-federal share, so the LPPF arrangements. HHSC at this time is moving forward, however, with implementing the programs and collecting IGT, particularly the IGT needed for the second half of the CHIRP program for the first year. Next slide, please. So as has been mentioned, the approvals require HHSU is requiring IGT on a really accelerated timeline. This approval in March is coming 7 months into the program year, and so they are wanting IGT for the CHIRP program for the final payment of program year 1 by April 18th to secure those payments coming in as soon as possible. CHIRP is only one element of what's going on here. Their directed payment programs are approved annually. So not only is HHSC kind of scrambling to implement these directed payments that were just approved for year 1, they're also implementing processes for year 2. And but that's not approved yet at this point. And so with this remaining uncertainty in the timeline and the funding amounts going forward, we're still operating with the best information we have, but always not as complete as we would like it to be on the timelines that would be ideal for us. Final slide, please. So tonight, staff is coming forward to you recommending an amended LPPF payment rate for FY22 of 2.36%. That amount of money will generate about $53.6 million and will allow the LPPF to maximize funding for that final CHIRP program year 1 payment that IGT is needed in April 18th. We do anticipate coming back to request an additional rate amendment once additional information is available for subsequent supplemental payment programs and also the final uncompensated care payment program right now. You know, in general, when we make these amendments, we know it is the desire of the board, and it is the part of our role to maximize the funding that's coming into the community. We also want to work with the best information that we have available. So that is why tonight we are recommending the 2.36% amendment. And with that, I'll close and take questions.
Thank you very much, Katie, for the presentation and the information. I'd like to now open it up for questions or comments. Manager Zamora?
No, I'm just wondering.
Turn your mic on.
Sorry. The hospitals wanted to go 4%?
Katie, could you address the fact that the hospitals wanted to go 4 and we're recommending 2?
Yes. So tonight, 2 hospital systems spoke in support of a higher rate, 4.04%. That was Ascension Seton and Baylor Scott and White. We also have emailed input from HCA, St. David's, that they are in support of the 2.36%. So we have, and there are other hospital systems that we do not have any, have not heard one way or the other, but do not have any opposition to that recommendation. A lot of the difference of opinion here relates to the timing of when funds are needed and varying levels of risk, this is my understanding, varying levels of risk that hospital systems are willing to take in terms of agreeing to a certain rate. I can tell you that the 4.04% rate would generate approximately $112 million and would fully fund the April IGT for the CHIRP program year 1, and also the expected early June IGT for CHIRP program year 2. Right now, we don't know if program year 2 is approved, but there's also not strong indication that it won't be. So, you know, I think that's kind of how it comes down on what they agree to fund with what particular rate.
Okay. And they did understand, Dr. Zamora, I thought I heard both speakers say that they were comfortable with 2.36 if that's what we approved, but we will have to come back next month and look at another rate so that we can cover the next IGT that will be coming forth toward us.
And that's what I heard as well. And I know this money comes from them, not from us. So
Right.
Why couldn't we just go with 4? And
well, because according to Katie, there's really not enough information that's known at this point in time, and so there's nothing to support that we need to go up to 4 to be able to meet our obligations and bring down the most money for the individuals. So it's not that we think it's a bad idea, it's just that there's not enough information at this point.
No more questions.
Thank you.
Thanks.
Manager Brinson?
No, I understand now. Thank you.
Manager Greenberg? Manager Jones?
I'm just, my question is similar to what Dr. Zamora said, is that, is there any reason the hospitals, knowing what we know, would ask for 4?
I don't know that I have that information to be able to explain what their thought processes were. Katie, do you have any additional information as to what their thought processes were with regard to 4, besides the fact that it would cover a number of IGTs?
I believe that's what their thought process is. And, you know, as the speakers earlier mentioned, it could change how we look at amendments going forward. It certainly would. The fact is, regardless of what we set tonight, we will probably have to come back again, and it's a matter of timing. And
so even if it's 4, you envision us coming back again eventually?
Yes, we would have to come back. We're going to have to come back with 2.36, and we're also going to have to come back for 4. But it has to do with the timing of us paying the IGT.
Right. Okay. All right. Thank you.
Dr. Zuniga? Okay. Manager Musaiti?
I don't have any comments, but I would I'm going to reference a paper, an article that was published in the Texas Tribune about this payment. So it would be helpful for board members and community to read about the LPPF and payments. Thank you.
Thank you. Manager Valadez?
Unmute myself.
I can hear you. Not now.
Yes, I saw that article and about the LPPF. And so my question is this: you keep talking about timing, Katie. So I'm trying to understand, if you don't mind explaining it a little better. We know that it needs to be a higher rate. We're going to have to come back and address this very same issue next month. We're going to have to come back and address this issue in the summer. The speakers acknowledged that. And so my question then is, are we the ones that are setting the rate, or are they coming together in advance or with you and talking about the rate?
We talk with stakeholders in advance to develop a recommendation. Then we review that and send, as staff, recommend that to you. The setter, the entity that sets the rate, though, is the Central Health Board. So it is in your prerogative to make that decision.
And if we, and so if, just to follow up on that real quick, if we were to approve a higher rate, let's say not necessarily this month, but next month, so that, and we're holding the money for them to do the IGTs, is that what you're referring to as a timing issue? Do we have to just ask for the money first and then immediately send it off? Or is there any constraint to holding that money in the account so that it can be sent as needed?
There's no constraint to that. That is certainly an option the board could take.
Well, if you don't mind offering that to the hospitals so that they can at least be have some advance notice about that. We're having our board meetings. They're going to take action. How do you all feel about this? That would be, I would feel a lot better knowing that they all are have input, but that they also have knowledge that yes, we can get this money. We haven't sent it there. That's all we do is just hold the money for them, correct? And then send it up when we IGT to the feds. So yeah, I think that would be maybe a little bit more efficient for us. That's why I was, as soon as Dr. Samoto started to speak, I was like, yes, that's right. Let's go for the 4%. Anyway, those are my thoughts. If you could just let them know. Thank you.
Certainly, certainly.
Thank you, Manager Valadez. I think that staff work very closely with the hospitals. And as I said before, it was the recommendation of the staff that there was not enough information about the future IGTs and whether or not they would even be approved, since CMS has the right to continue to review our program. So it was in the best interest of our fiduciary responsibility of going with the 2.36 and then re-examining it when we had additional information. So thank you very much. Manager Motwani, any questions or concerns?
Yeah, I guess if Chair, if I could ask Katie, one of the comments I think we heard from Mr. Galinsky earlier, and I think among, or at least across the public testimony on this, it seemed like the most compelling reason to go with the 4.x rate was that it would be burdensome for Central Health staff. That was the most compelling, at least enumerated reason that I heard. I think it was you who was speaking about again, presumably the risk notion. That was really the other more compelling notion that I heard, but I think that was questionable, you were saying on your part. So is the notion that it's burdensome for staff salient as compared to what staff recommendation is as it stands right now, which is 2.36?
So we, of course, as staff and as being cognizant of your all's time, would love to set these rates and to make these changes and send out invoices, which we do as few times a year as possible. But we also want to work with the best information available. And we are not suggesting anything that our staff can't handle in terms of implementing these rate changes as we need. Although we're very grateful for the acknowledgement of that and the recognition that it does take time and energy on our side to implement those changes.
Thank you. Thanks, Chair.
Thank you, Katie. I appreciate that. Any other discussion before I request a motion? I recognize Dr. Brinson for a motion.
I move that the board amend the FY 2022 Local Provider Participation Fund, AKA LPPF, mandatory payment rate as recommended by the staff.
Do I have a second? I have a motion from Manager Brinson. I have a second from Manager Greenberg. Any further discussion? Hearing none. All in favor?
Aye.
Aye.
Any opposed? Any abstaining? Motion carries. Thank you very much, Katie and staff. We appreciate all the information and the hard work that you've done to bring this forward to us.
Thank you.
Agenda item number 2, receive the fiscal year-to-date healthcare service expenditures made by and accept the preliminary February 2022 financial statements for Central Health and Community Care Collaborative. Lisa Owens will be presenting.
Good evening. Can you hear me okay?
Yes, I can. You might speak up just a little
great.
bit.
Okay. Good evening, Lisa Owens, Deputy CFO. I'm here tonight to present our financial statements as of February 28th. Let me put it into full screen mode for you there. Hopefully you can see that. We are 5 months into the fiscal year. The highlight of this month's presentation for Central Health is that we have reached the point where we've collected 99% of our tax revenue, which, as you know, is the primary source of our revenue. And you will see that also puts us at a high point of our cash, which is $507 million. Other current assets, we also have restricted for capital acquisition, which includes funds that were received for bond proceeds of $78 million. Our total restricted cash, which also includes the LPPF funds as of February 28th of $1 million. Again, our total restricted cash and investments and non-current assets are $191 million. We also have our capital assets, which includes land and buildings and equipment. Total assets for the period ending February 28th at $784 million. Looking at our liabilities, we have a fairly low ratio there of current liabilities, with just $21 million in current liabilities. That is primarily made up of accounts payable to vendors, but also to healthcare service providers. And then we also have, again, the funds held for the LPPF of $1 million, and our debt service, which was issued last fall, of just over $80 million. Our total liabilities at $102 million. We also have our net assets of $682 million, which as a result is our liabilities and net assets, which equals, again, $784 million. Looking at the month of February, that our sources and uses, as I mentioned, we did collect an additional $26 million in tax revenue. That puts us at about 99% of our budgeted tax revenue. We will start to see that really start to slow down as we get in towards the last 6 months of the year, as those taxes were due in January. Other sources of revenue are interest and lease revenue. We had healthcare delivery expenditures of $11.8 million. I'll discuss that in more detail on the next slide. We had administrative costs this month of $451,000, total year to date, $3 million, just about 23% of what we budgeted. And our total uses of funds were $49 million year to date, which puts our excess sources over uses at $448 million. Looking a little more detail at the healthcare delivery costs, you'll see about 25% of our budget has been spent in our healthcare services, which includes primary care, specialty care contracts. And as you know, we have more detailed slides a little bit later in the presentation. Also, about 38% of our funds In the ACA Premium Assistance Education and Enrollment Program, we were able to enroll additional participants in our high-risk program this year. We are on track with our budgeted dollars there. And our total healthcare delivery for the month, again, was $11.8 million, and year-to-date, $45 million. Looking at a little bit more detail here, we do have a little more information about our healthcare delivery operating costs, as well as our healthcare facilities and campus operating costs. And also you'll see our debt service and reserves and transfers. We did make our debt service payments in February for our new issue. Those are due annually in February, March timeframe. We did make those payments. And again, our total healthcare delivery is $11.8 million for the month. We do have additional information about our primary care contracts and by partner here, as well as our specialty care services, the dollars spent by specialty. And as you'll recall, we went ahead and broke out our expansion dollars at the bottom here. Those expansions would be brought to you specifically as those get up and running. But you'll see we are at, for contracted specialty care services, about $2.4 million year to date, about 20% of the funds that were budgeted. And with that, I can answer any questions about Central Health, or I can move straight to the CCC and answer questions at the end.
Thank you, Lisa. Managers, do I have any questions with regard to the budget?
I do.
There you are. Okay. Manager Valadez?
We're still having problems looking at the screen. So, but anyway, mine are going to be pretty quick, Lisa, and thank you for the presentation. Let me look at my sheets. I think I'm going to start backwards. For MAP basic expansion, we have zero spent, and I'm just curious as to why there is not any money spent. And on that same sheet, we only have used in the specialty care, we've only used 14% of our specialty budgeted amount. I'm wondering why that is as we look for increasing specialty care. And then with community care, they've used about 34% in 5 months of their budget. Is there a lessening of patients going into their facilities, and do we have that information that would show, I guess, in the different FQHC clinics, whether or not they are at full capacity and are they being used? I have a question, I guess, when we speak about the Senderos stuff on ACA or CHAP and high risk premium stuff, but I'll ask that when we get to that. And let's see. Also, what are the operating costs on the healthcare delivery? Operating costs. What do we consider operating costs? Is it administrative costs, that kind of thing, equipment, etc.? If that's it, then that's fine. I get it. And with respect to our healthcare services, primary, last year for year to date 2021, we had $18.8 million in healthcare uses for primary, and budgeted for 22 is 59 million, but we've only used about the same amount as we had budgeted for 21. And when I'm seeing such low numbers, that I'm seeing increased what looks to be funding or in contingency amounts, that I'm wondering, why are we, I'm trying to figure out what is there a disconnect that our patients are not utilizing the services that we're offering them, according to what I'm seeing. And on page 5, back to the that $80 million for debt service, I'm assuming that's for the Sears building. And then on page 6, there's that contingency fund $506 million in the contingency fund, when I'm not seeing that we're not even at 45%, much less 50% of the services being provided in primary and specialty care.
Manager Valdez, you've run out of time. Lisa, if you want to attempt to address a few of those items here for a very short period of time, or if we can get with Manager Valdez offline and address her concerns.
Certainly, I cannot address all of the specifics. I apologize. I was not following the exact numbers. I know the page numbers you were giving me towards the end there, but I can go back to the beginning about primary and specialty care, especially our primary care partners. I do not think we are seeing any issues with service delivery. I do not have utilization numbers. As you know, our healthcare services team has that, but we have not had any information that's indicative of that. I would like to point out with our primary care contracts, we do have a lot of incentives in those contracts, and some of those are not realized until midpoint in the year, end of the year, and the timing on that. So I can certainly follow up with more information about that. And then also your question about the expansion programs. We did put funds into the budget for potential expansion of services and things, and those projects have not started yet, and therefore those dollars have not been spent. But those funds are there so that as soon as those projects, which would come to this board, are started and begun, that the funds would be available. There were quite a few other questions that, again, I'm happy to follow up. I
have them written down. I'll send them to you, Katie. I mean, Lisa.
Yeah, if you could do that, that would be great.
Thank you. I appreciate it.
I'm happy to do that.
And also on the contingency fund and what we have scheduled to use for it. Thank you.
Thank you, Manager Valadez. Any additional questions on the budget? Lisa, did you need to go over the CCC budget or?
Yes, I will share my screen again and quickly go over the CCC financials as of, keep wanting to say March, but as of, as of February 28th. So as you know, the CCC has been very consistent over these past few months with last year. And that's always good to see consistency. And so our total assets are at 19 million, which is very similar to this time last year. We also have total liabilities of about 12 million. And the slight increase year over year there is just holding back funds for revenue that we've received for the DSRIP program. We have had third-party audits of that and never had recoupment from those audits, but we do hold back funds because that process is ongoing and it will continue to go forward. So we reserve those funds there. Our net assets are at 6 million and our total liabilities and net assets at 19 million. Our DSRIP revenue is anticipated in the summer. You will recall this is an adopted budget from FY20. We do anticipate the DSRIP revenue to be less this year than the budget because of the program requirements. But we anticipate that timing to be the same, which is this summer. In our healthcare delivery program, we do have services, which I'll go over on the next page, as well as the DSRIP project costs. So our net our total uses year to date about $8 million. So that $5 million in healthcare delivery in the CCC is predominantly in our post-acute care program and contracts, as well as urgent care, but also the very large commitment to behavioral health through our partnership with Integral Care. And again, you can see very consistent estimates with last year as those programs continue to serve patients. So those are really the highlights of where we are with the CCC. And again, I can answer questions about CCC.
Thank you, Lisa, again. Any questions from our board members? I see none. Manager Jones? Oh, and I'll get to you, Cynthia. I'm checking here first. I saw you. Manager Jones?
Well, I didn't have a question. I just had a comment. I think we should acknowledge the great work and the award that was awarded to our enterprise for the work they've done. So I'm going to ask Mr. I think you can take the question from Manager Valadez and then ask the manager, the
Mr.
CEO,
Giesland.
to talk a bit about the award.
Okay, great. Manager Valadez?
Yes, this is going to be relatively quick. Lisa, I'm going to also forward you some questions that I have about this budget. Also, it'll be in there. And with respect to what I think two of our public communication speakers had asked about, and that was it would be, I guess, with respect to the integral care budget. I know we can't control what integral care does, but we can control what we give them and ask them what it's being spent on. And if there is a way for us to communicate to integral care, Dr. Samora, that we look at making sure that methadone is I thought it was already an accepted service that we were providing right there on 2nd Street, because that's where I take Gloria, but not for methadone. If there's any way to handle that, I'd appreciate that for the opioid abuse and also for the heroin addicts. Thank you.
So what is the question, Manager?
Thank you, Manager Valadez.
I guess just if you could let the Integral Care Board know that we had some speakers that were asking that be addressed in their budget, but since we do give them monies, if it would be possible for us to see what their budget is as to whether or not they're spending money on those kinds of treatments that the public communication speakers were wanting us to look at, which included methadone and for substance and opioid and abuses.
We have our board meeting tomorrow. I'll let them know, and our retreat on Friday.
Thank you, Dr. Somlet. I appreciate it.
Thank you, Manager Valadez, and thank you, Dr. Zamora. Any additional questions on the CCC budget? I am seeing none. Therefore, I will read the next two agenda items. And I'm sorry. Oh, I'm sorry. Yeah. Mike, I'd like to recognize you to outline the award that we received for our budget and financing.
Yes, thank you, Mr. Chair. Mike Giesel, President and CEO. I want to thank, first of all, Jeff and Lisa and everybody on the finance team and those that there at the end that are not part of the finance department to really help with the heavy lift to meet the submission deadline. Monica Montes and Camila Rodriguez that were also part of that effort. And members, this is the third year in a row that Central Health has been recognized with the Government Finance Officers Association, also known as the GFOA Award. And from the budget booklet that is put out every year to all the engagement opportunities and all the detail that go into our budget, and especially when you compare us to other hospital districts in terms of their budgeting lines, there's a lot that goes into getting this award, but it is something that the County Commissioners Court had encouraged us to do. We've been pursuing it. And I think it's a mark of transparency and integrity that we can wear proudly and continue to excel to meet those standards. It is good for this organization and good for the community. So thank you for allowing me the opportunity to say a few words. Thank you, team.
Thank you, Mike. And again, thanks to the finance staff for their excellent work and for being recognized in such a way that outlines the diligence by which we go through our finances and create our financials so that not only the board can understand and ask questions, but also the public and have a idea and certainty of how we are spending the taxpayer dollar. Thank you again. Okay. I'm going to read the next two items and then we'll bring us into closed session.
I believe item 3.
I'm sorry. I did miss that. Sorry. Thank you very much. Agenda item number 3, receive and discuss a report of historically underutilized businesses spending performance for fiscal year 2021. Alina Bunch and Lisa Owens will be presenting.
Good evening, Board of Managers. I'm Belina Bunch, Procurement Manager for Central Health. Can you guys hear me okay?
Yes, I can, Belina. Thank you.
Okay. So we're here this evening to present our fiscal year 2021 historically underutilized business report. Our report this evening shares an overview of the expenditures that Central Health had with minority and women-owned businesses who obtained their HUB certification. Next slide. Our current purchasing policy states that Central Health will make a good faith effort to engage HUB vendors. What is a good faith effort? It's the outreach that we do to find HUB contractors for all solicitations we issue. We also encourage vendors and prime contractors to include minority subcontractors in their proposals, as our solicitation documents outline the requirement that vendors make a good faith effort. For the purposes of identifying the eligible expenditures that Central Health had in FY 2021, we measured participation in the included categories listed above. You can also see the expenditures not included, one of which is healthcare services. Fiscal year 2021 has 6 formal solicitations, with 2 of those being us obtaining a general contractor for our Del Valley and Hornsby Bend clinics. We use a nationally recognized purchasing platform, which is BidSync, to alert and manage our formal solicitations. And this summary provides an idea of the expansive outreach that is available, showing that we notified over 132,000 subscribers of our solicitations. Subscribers are also notified based on their identified commodity codes that match our solicitation activity. Throughout the alert, review, and submission process, we had between 22 and 38% HUB subscribers identified. 2 of the 6 awards in FY21 were to vendors that identified HUB subcontractors in their proposal to assist with performing the work. These were awarded in FY21. However, the expenditures could be paid over future periods due to the timing of the projects and service delivery. For example, the construction projects will be paid over multiple years. We work closely with our communications and real estate teams to develop targeted outreach for our construction opportunities. We also expanded our distributions to chambers and trade organizations throughout the state of Texas, and not only in the immediate Austin area. The photos that you see are the flyers that were distributed to those organizations. In FY21, we also had 12 informal solicitations, which included 2 small construction projects, 5 professional service projects, and 4 IT hardware and network equipment purchases. Informal solicitations are conducted through email distribution and cooperatives, opposed to being posted on BidSync. These projects are generally awarded on the ability to meet the specifications and lowest price. Our outreach and distribution methods are similar to formal solicitations and distributed to trade organizations and chambers when appropriate. We capture our eligible expenses for the fiscal year in 2 categories: operating expenditures and capital improvement project expenditures. Our total eligible expenditures were $17.7 million, and we spent approximately $3 million or $16.8 million with HUB vendors. When we look at the historical comparison over the last 9 years, FY21 shows an increase in both operating eligible and hub expenditures, as well as a continued upward trend in the number of hub vendors we work with on eligible expenditures. So how do we compare to everyone else? Looking at the percentage of hub expenditures for the state, the city, and the county, based on the most recent data available, we compare favorably, with 16.81% or approximately $3 million in eligible expenses with hub vendors. We report out on the classifications based on the self-reported hub status of the vendor, on their certification provided by the city, the state, or other hub certification organizations recognized by Central Health. The hub classifications that make up the $3 million include woman-owned businesses, 19%, Hispanic-owned businesses, 76%, Black-owned businesses, 4%, and Asian American businesses, 1%. And now I'll turn it over to Lisa Owens, the Deputy CFO.
Thank you, Belina. We also prepared a 3-year trend for our presentation tonight that looks at the details of our capital improvement program in more detail. We've seen an overall increase in our eligible operating and capital improvement program expenses over the past 3 years, as you'll see from this table. However, we wanted to look at what the majority of those capital improvement program expenditures were. And you will see that it has been in technology and IT professional services, which is a category that has limited opportunities for hub participation because of the specialized services and vendors required. In this case, it was the purchase of our electronic health record that was increasing those costs over the past couple of years. Our construction and facilities projects have been fairly steady, and with the 2 major construction projects that are starting in FY22, we will continue to see more expenditures in that area, and that has significant opportunities for prime and subcontractor hub participation. Looking forward, we do look forward to being back in May with our consultant, Colette Holt and associates, to present the results of the disparity study. What will come after that is a program development recommendations from management, as well as we're already starting to increase our data collection through new systems on finance and the procurement team, which will help support future reporting and hub data. We're also working more every day, ongoing. We learn from every solicitation that we post, whether it's a formal solicitation or an informal solicitation. We are always working to fine-tune the outreach and awareness. We're expanding our efforts and planning to host additional outreach activities for additional construction projects that will be coming, small, medium, and large. We will make similar efforts as we did for Del Valley and Hornsby Bend that Belina shared with you earlier. And we will have our own Belina Bunch talking about how to do business with Central Health on the KVI radio show in the next few months. And also, I just wanted to point out, which is included in your slides, just the ongoing outreach efforts that we continue to enhance, using BidSync and the ESBD to get the outreach out to as many hub and small businesses as we can. We use our website, social media, large and small local print media, and direct communication with our chambers and trade associations throughout the state. So we look forward to being back with you in May to talk more about how this program will evolve. And at this point, we're happy to answer questions.
Thank you very much, Lisa. Those numbers are much improved. And we really appreciate the hard work that you've put in to make, you and your team have put in to make those changes. I will start with folks online this time. So I will start with Manager Valadez.
Okay, am I unmuted?
No, yes, you are unmuted. That's correct.
Thank you. Thank you so much, Belina, for that good information. On page, I'm assuming it's not page, it's on the formal, under the formal solicitation summary. So on the 5 contracts that we actually awarded, and I'm assuming this is for eligible expenses. So basically, the three, there are five. 3 have no hub participation, and 2 do have hub participation, but only as subcontractors. Do we happen to know whether or not those are those 2 particular contracts with the subcontractor, hub contractors, are those people that we have contracted with before? And if they are before, or in other words, are we keeping this data up, regarding previous, to know whether they continue to use the same hub subcontractors, or whether the subcontractors themselves are able to submit on their own? And that was always a concern of mine, because if we continue to be subcontractors and we never get to be a hub applicant, it could be because of maybe some additional requirements that they cannot meet. Do you know if that's the case?
So Manager Valdez, I can look up that information for you as to the 2 vendors that have the subcontractors, if they are repeat vendors for us. I can also let you know that when we host our pre-proposal conferences for our solicitations, we ask everyone to sign up. And when they sign up, just as they're signing into a meeting, they let us know if they are prime or subcontractors. We make a list, and we make that list public for everybody. We post it on BidSync, and we send it to anybody who requests the list to let them know that I'm a prime contractor who's interested in sub-hubs, or I'm a sub-hub who's interested in partnering with the prime. And then people who are subcontractors and are not hubs, we always try to encourage and let them know, that they can benefit more from the state of Texas entities, at least if they go through the process of becoming a hub contractor, a hub vendor.
Thank you. Just one real quick second one with respect to Spanish speakers, because I know that that's especially in the construction trades arena. What are we doing for anybody in Spanish other than El Mundo? El Mundo is not a place that you're necessarily going to attract any hub bidders from. But I know that there are several radio stations in Spanish where they are specifically talk radio that would benefit from someone who is going to speak to in Spanish to our contractors, because we have IT contractors. I know 2 different groups that are IT contractors, including the great group that provides Dr. Zamora the medical health information. So I'm just curious as to whether or not we have any efforts in that arena.
That's some great information that I'll be able to take back and hopefully be able to capitalize on this year. But I can tell you that we also advertise in the La Base newspaper. And if we have, the La Base. And if we have any written or print communications that go out as the flyer that you saw, we do have those produced in Spanish as well as English. We do also solicit or send them to the chambers, like the Austin, the chambers that can
all the minority
communicate in
chambers.
Spanish. But the radio station is a great idea. So thank you for that.
I've been suggesting that since day one. But
thank you, Manager Valdez.
Appreciate
it. Manager Musaite, if anything? No? Manager Matwani?
I obviously, for a lot of reasons, appreciate the presentation as well as seeing the upward trajectory. And I just want to kind of, I want to make sure, though, of course, we all appreciate what's clearly a strong and unrelenting focus on expanding equitable opportunities for historically underutilized businesses. It seemed like grand total hub expenditure growth from 20 to 21, though it grows, is sort of dwarfed by grand total expenditure jump from 19 to 20. But looking at the one with the orange and blue bars, the orange bars just don't climb as much. And but there's still growth, and it's still important. I'm wondering if there was maybe an idiosyncrasy there, or maybe something that doesn't get caught by the graph. Maybe there are more vendors but less expenditures. That's my first question. And my second one is, what opportunities are we seeing, where we should double down and maybe work more? And I know it's, when we're presenting what is showing really a celebration in some ways of the great work we're doing. It may not, it could be a little souring to hear, well, what can we do more and what can we do better? But, since you all are working directly in the arena and are so close to the ground, I'm just curious what you're seeing and where you think there may be opportunities for us to do better from your angle.
So when we talk about the expenditures going up from 2019 to 2020 and then down again from 2020 to 2021, I think the demolition project, Lisa, correct me if I'm wrong. I think it was the demolition project of the campus that helped us in 2020. Lisa, you can see.
Yeah, we have not had any. We have had the demolition, which had high expenditures in 2020. So I think, Manager Matwani, what we're seeing is incremental growth in kind of our operational expenses. But then when you look back at that chart, the years that we had extremely high percentages was when we had large construction projects, and we just have not seen those dollars starting to be spent until now. You are going to see in 2022 and 2023 a lot more expenditures for construction projects, small and large, with the work that you saw at the groundbreaking last weekend and another groundbreaking next weekend, as well as I believe the next presentation you're going to hear about other construction projects. So that is a big part of that, and that was a good point to bring up, Belina. As far as the additional outreach, we are always working on that, and we're talking about, there's not a lot of fairs and face-to-face opportunities. So how can we get out there and have a cycle with our community engagement team to continue to just increase our messaging, change the messaging, and get out to different communities to improve the participation. And so we continue to do that work, and always looking for good suggestions from all of you.
Thank you.
Manager Matwani, do you have a quick follow-up?
It is a quick indeed follow-up, and it can't be answered online, perhaps offline, but I am curious as to the hubs that are African American led or Black led. If we may be able to get a better cross section on where the concentration, or basically what the breakdown of the types of expenditures those are for those particular vendors. I'm just curious about it, and and also obviously it's an area of opportunity, and I'm just wondering where the levers may be that we could move to help improve that, despite of course 400 years of systemic and brutal racism.
Sure.
Manager Valadez, very quick. I'm sorry,
detail.
Lisa, go ahead. Answer his question.
Oh, I was just going to say, we're happy to follow up with those details offline. Thank you.
Thank you, Lisa. Manager Valadez, very quick.
Very, very quick. One of the historic comments that I have made is with respect to women-owned businesses in the hub component. It's not disaggregated, and I have asked for it to be. Are they Black women-owned? Are they brown women-owned? Are they Asian American women-owned? That is not there. To just lump all women into, all ethnicities and cultures into one, I think it's not correct or appropriate. So if we could please disaggregate that, I'd appreciate it. I have brought this up before. And another place to go for looking for minority vendors might be with the Economic Development Corporation through the city of Austin and the county and other areas. That's another place for us to look for possible hub contractors.
Thank you, Manager Valadez. Did Lisa or Belina have any comments with regard to that? Okay, thank you very much. Mike?
Yes, and I think part of this, the disaggregation goes to what type of certification that is sought, and then the data sets that are available to us. And I know I'll let Lisa or Belina speak to in the future. Maybe when we bring back the disparity study, we can talk more about, what data is disaggregated, is out there versus what do we need to collect. perhaps more on a manual basis to be able to come back and answer some of these questions. But that's the challenge that we run into. And on the notion of the mention of the disparity study that's forthcoming, and I think this gets to Manager Motwani's question, there's a lot that we're going to be able to see. And what disparity studies do is they give you a clear lane to go down in setting very specific goals for hub programs. And I think there's a lot of the ideation maybe that we've had, with not only with the board, but as staff, but then with that disparity study, we can start focusing in and developing concrete plans to say, yes, this is specifically what we can do to be a lot more assertive and deliberate in historically unutilized business programs, and also working with county and other governments. Thank you.
Thank you for those comments, Mike. I appreciate that. I've seen you. Dr. Zamora?
No questions.
No questions. Dr. Princeton?
So I did want to ask the question, even though it was alluded to by Manager Valadez. So if there is someone like a Black female, they get counted in the female category only?
It depends on how they register, which is kind of what Mike was alluding to just now. So if I'm a Black female and I want to register with the state, I can choose to register with the state as a Black American female business, or I can choose to register as a woman-owned business. So it really depends on where we register, where the vendor registers, and what they choose, what they think is best for them.
Thank you.
Thank you, Belina. I appreciate that. Manager Greenberg? Nothing. Manager Jones?
Yes, I would just like to ask, I mean, we've been through this for several years, and I guess I'm a little concerned that when I look at these numbers, particularly for African Americans, I understand that you're saying it may not be truly reflective of African American females, that may be reflected in the female women-owned businesses. But particularly 2020, I assume that's primarily pandemic related in terms of lack of numbers. But here we are 2021, and actually it looks worse than 2019, which might be spillover effect also. So I guess my question is, and it goes to what Mr. Motwani was saying, is that do we actually have a aggressive, I know you're looking at the disparity report that you're looking at, Mr. Geisler, but the African Chamber of Commerce is quite busy here and quite well known and quite well connected. Are we doing any kind of efforts? If not with that, then we have the city of Pflugerville and others who are making great strides in terms of addressing this. Have we actively gone out and tried and get African American businesses engaged in some of the work that we need?
I would say
Yes,
yes,
sir.
we
And
have.
I'll let, I'm sorry, Belina. I'll make a few general remarks, and then I'd like Belina to comment. So it's right now, and what you saw in the earlier slides, the strategy is to increase the outreach, and then as we find new opportunities, go engage in those opportunities. Now, it's been challenging during the pandemic, but I think as we're opening up more, the opportunities that we had pre-pandemic will hopefully start to come back, be it with minority chambers, other cities. And I'm not sure if we've ever partnered with Pflugerville on something like this, but I think that's an excellent idea. But there's a lot that we can do now that we're, hopefully, knock on wood, coming into back to the pre-pandemic business environment where we can engage more with businesses. And so it's really on the strength of the outreach, as we head into the final days of the disparity study and seeing what other more clear paths we can take. Belina.
Yes, sir. And I was also going to say that now that we're getting out more, we're also engaging with Travis County. Their hub coordinator and outreach coordinator has been a great help to us, even with us getting ready to develop our hub program. We have had conversation with Quincy, I don't know his last name, with the Urban League.
Dunlap.
Yes, so we're also sending him information, calling to see if there's anything else, if they need any other information. Whenever we have solicitations, his email is included in all solicitations, so that, and we're asking them to post it, or to send it out to their members as well. So as far as right now, leading up to, for FY21, I would say that we've done as much as we thought we could, but definitely looking to do more coming up.
Thank you, Belina. Manager Zuniga? No? Thank you. Okay. Thank you very much for that presentation and the hard work you guys have done. Okay. I will now proceed to read agenda items 5 and 6 and then outline that we will be going into closed session to discuss those agenda items. Agenda item number 5, receive and discuss updates on the 1115 Medicaid waiver, delivery system reform incentive payments, parentheses DSRIP program and associated projects, the Community Care Collaborative, and other healthcare delivery partners, programs, projects, and arrangements, including agreements with Ascension, Texas. Agenda item number 6, receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District, DBA Central Health, and Mike Gieslin, cause number D1GN17-005824 in the 345th District Court of Travis County. It is March the 30th at 7:18 p.m. I announce that the board is convening in closed session to discuss agenda items 5 and 6 under Texas Government Code Section 551.071, consultation with attorney. I have a quorum. David, is it okay for me to? All right. It is March 30th, 8:16. We're coming back into open session. We've completed our closed session items. There was no action required on agenda item 5 and 6. Agenda item 4, receive an update and take appropriate action on fiscal year FY 2022 capital expenditures for the renovation of Rosewood Zaragoza Health Center for the purpose of providing multi-specialty clinical care health services. Jonathan Morgan, Stephanie McDonald will be presenting. Welcome, guys.
Thank you, Dr. Bell. Is my microphone good?
Your microphone is great.
Nice to see you all in person. Thank you for your time this evening. I know we're running a little short on time, so we'll jump right in. I'm John Morgan, Chief Operating Officer, joined by my colleague Stephanie McDonald, our VP of Enterprise Alignment and Coordination. Tonight, this is an action item. We have a request to move forward, and we're very excited to make this presentation as this is a big step in advancing Central Health's direct provision of care in the form of multi-specialty clinic services at Rosewood Zaragoza, a longstanding health center in our system. Would you go to the next slide, please? I don't know who has the slides. Thank you. Okay. So to start off, as a reminder, this work stems from the board's long-term focus and prioritization on building capacity and improving access to specialty care for our patients. Improvements to specialty care on this slide, as a reminder, were outlined in our FY22 budget resolution that was adopted by the board. It's one of our named clinical focus areas, and honestly, I can't remember a year since I've been here that it hasn't been a named priority of the Central Health Board. So we're very excited to bring this opportunity to you all this evening. I should also mention that access to specialty care, filling specialty physician shortages in our community, and making improvements to access were also identified in our performance review by Jermaine several years ago. We also recently completed the First, safety net focused community health needs assessment here at Central Health through our strategy department. There are over 100 pages of analysis, data, interviews with stakeholders, the voice of the community, our patients, our providers, that also identified significant gaps in specialty care and quantified some of those gaps. Specialty care, again, was prioritized in the equity-focused service delivery strategic plan that the board just adopted recently, but we won't rehash all of that data tonight. We also spoke in some detail about the scope of this project at Strategic Planning Committee earlier this month. So this is a continuation of that discussion. I should also mention that Central Health staff at the board's direction over the past few years has been pursuing the provision of direct services and the ability to directly hire physicians and to practice medicine here at the healthcare district, starting with changing Central Health's enabling legislation, establishing a medical executive board and all of its committees, hiring our first chief medical officer who's here in the room, as well as other medical directors in different areas. So a lot of work has been happening over the years, really in the background, to prepare for this ability and for this tool in our toolkit. Next slide, please. So this is a very similar slide to the one that was presented at Strategic Planning Committee earlier this month. Again, I will only hit a few highlights, starting with each of these 5 specialty care service lines that are shown on this slide are areas that we have had significant gaps in access. We have not been able to meet the needs of our patients the way that we would like to. The wait times, despite our best efforts in our current model where we contract almost exclusively for services, the wait times for these services are between 2 and 6 months and even exceed 6 months at certain points. So that's really why we're looking to focus on these particular areas. I'd also like to just call out the collaborative care team portion of this. I mean, we intend to provide comprehensive wraparound services in the form of a registered dietitian, a clinical pharmacist, case management, behavioral health services, all as part of this model as we put it in place. Another big differentiator here is the far right-hand column. The equipment you see are the diagnostics that are specific to each of the specialties. Right now, our patients, in many cases, access specialty care in these service lines within community care, and then they have to go to a hospital in order to have necessary diagnostics, and then they have to go back to community care for the interpretation and treatment based on those diagnostics. So part of what we're hoping to build here is more of a one-stop shop that really tries to prioritize the convenience of our patients and also the ease of getting the tools in the hands of our providers that they need to care for our patients. I should also really try to emphasize here that nothing that we're doing at Rosewood Zaragoza, no part of this proposal is intended to replace any existing services. It is not intended to supplant or in any way relieve any of our contracted providers' obligations. So those obligations and those services should continue. We're also not building direct clinical services at Central Health in a way that excludes working with other providers in the community, including community care, including our partners at Ascension, at the Dell Medical School, and the many other private practices that we work with around town. In fact, we're pursuing professional services agreements in multiple specialties right now that are shown on the screen. So we will continue to do that. We will continue to partner. And again, our direct ability to practice medicine at Central Health is intended to supplement and fill gaps where we can't do that with our existing partners in the community. I should also mention that there are dozens of people sitting behind me and Stephanie that are both in this room and not in this room that are contributing to this. A lot of staff here at Central Health investing time and effort, as well as our partners at Community Care and other clinical practices around town that are advising us on this. Today's presentation is focused on an immediate ask around the facility, but please know that we will be bringing back additional details on the programming, on the operations, on the financials for expenditures beyond FY22. The ask tonight that Stephanie's going to take over here in just a moment is really related to getting us farther down the road between now and the end of the fiscal year. Next slide, please. So as I've mentioned, we're looking at the Rosewood Zaragoza Health Center site as we presented at strategic planning earlier this month. And we're proposing to renovate what has been a long-standing health center in the community serving our patients, starting with the City of Austin. This is still a City of Austin leased health center, and Stephanie will elaborate on that as well. But this site presents a lot of unique advantages to us. One is that it's known to our patients, very, very well known, both as a primary care site, but also in the COVID pandemic. I mean, this was one of the primary sources of vaccinations throughout the pandemic. The location is accessible for our patients. It's both near our population center along the I-35 corridor, and it's also east of I-35 and more accessible for some of our underserved communities. It's also uniquely sized, surprisingly uniquely sized for the scope of services that was developed before this site was really even considered. So that scope that was outlined on the prior slide. There are also some cost advantages here for Central Health. This is through a low-cost lease through the City of Austin. We are hoping to extend that lease as part of this process before we invest significant dollars in renovations. And then I think the most important aspect here for Rosewood Zaragoza is timing. Having this site within Central Health's control, it's an existing location. It allows us to move faster to bring services online for our patients. So using an existing site like RZ should allow us to bring services online as soon as 18 months from now. A new development, a newly leased commercial location would easily put us more in the 3-year timeline to bring some of these services online. I will turn it over to Stephanie, but thank you for your time.
I think you're going to start to correlate my appearances before you with requests for significant funding. I'm not sure if I'm going to be invited back. So this is a test fit that was done internally by members of the team. And Don, you're supposed to say that there's just, it's me and you, man. We do have some great resources and expertise and skills that are now that we have not had, and it's been really exciting. They have done this test fit. This is something that would be essentially schematic design. And so even in that regard, we've been able to accelerate. Because we have a basic understanding that the program, what the services are going to be, will fit in this space, we think that it has a lot of feasibility. However, we do need to do a little bit more diligence. And John mentioned the lease with the City of Austin being one of them. Currently, our lease expires in 2034. Manager Jones, I'm looking at you. We might need some help because this is on Austin Public Health property. But we have had a very high-level conversation with the acting director of real estate. He is interested in exploring. Jeff is telling me in order to make a significant investment in this site, we need to be able to keep it just a little bit longer. I'm going to ask for at least another 10 years. If not, John's just like, well, why don't you just ask them to give it to us? I'll see what I get. But I would like to be able to have that conversation. And I'll just let you all know right now, not only for Rosewood Zaragoza, but for the other 2 original MAP clinics that came to us from the City of Austin, include South Austin and East at this point. There's not necessarily plans for those yet, but just if we're going to make the ask, let's just go big, right? So there are some things about the site that are unique. It is abuts there's a senior center, there's parkland involved. So this has been something that's come up as we've thought about previous attempts to redevelop the site or to rethink the site. So we are looking at making it better in terms of ADA accessibility, kind of reorienting kind of the position of the building to the north. So those are things that we still have to do. And then as you know, it's an aged facility. We have many nurses who are still with us who have been in that and worked in that site, and they tell us all about the plumbing issues and the electricity issues and the roof issues. There's a lot of issues. And we would like to bring on a design team now to make sure that we can suss out those issues before we, advance this project any further. And that is part of the request tonight, are for those design resources. And if you'll go to the next slide for me. Like I said, significant money when Stephanie shows up. We are looking and asking for a little over $1.1 million tonight, and it is to get us to construction documents. So we would go ahead and issue a task order to have architects and engineers design the site. But while they're doing that, doing the feasibility necessary and the building systems, there would be an interior demolition required. And if we could get to design documents, we could go ahead and ask for the city for the permit to do that interior demolition work and kind of be able to meet the very, very aggressive timeline that John has set forward. It's a goal, and I'm there to meet it, John. So we are asking for the money for this fiscal year so that we can go ahead. We will come back to you, obviously, if there is an issue and it's not as feasible, or there are significant additional costs that will be required in order to make this site work. We do know that time is of the essence, not only to serve our patients, but because we don't know kind of the volatility and the kind of dynamic nature of the construction market right now as well. So this budget right now is a preliminary budget that our team has put together. There is a lot that probably needs to be added to this, not just on the operational component, but on some of, depending on what service lines are offered, what kind of equipment is required. If there's new fancy equipment, that would be really meaningful in the care of our patients. We want to make sure that we are doing all of that work. And so this budget may change over the next few months as we go into fiscal year 23. If you'll go to the next slide for me, thanks. Stretch goals here, we would like to have first patients seen by the end of fiscal year 23. That is, of course, if everything works out, the stars align, the permits are issued, and that's being very creative. And one of the creative approaches that the team's come up with is to go ahead and try to jumpstart the interior demolition and getting the right professionals on board so that we can apply for that permit. So next slide. I do think it's important, though, that you all recognize kind of how this fits in with some of the other capital projects that are going on, the major facility work that the team is doing. A lot of this work, as you know, is underway with Hornsby Bend and Del Valley. We expect construction to commence by May, and so those projects will be underway. Rosewood would be next in the queue, and then, we also are not leaving off the Hancock Center. This would be additive, and I think John alluded to it. We are expecting and planning for a significant clinical presence on the ground floor of the Hancock Center, but this would be in addition to those services that are planned for that site. We've got some other capital improvement projects. That's small renovation to make the Runberg Clinic, which is a leased space, but to make it more effective for community care, and so they can see more patients within that space, and a couple of other clinical projects. And this may grow as we start developing the fiscal year 23 budget, but I wanted you to see kind of where we are at in terms of timing of our projects and just the resources that are going to be needed to make all of these dreams come true. And I think it's really great that we have the internal expertise, to kind of get us to this point. But if you'll go to the next slide, we are asking for the funding. This will allow us to bring on the design team, the architects and engineers required to do more feasibility, to go to the city, request extension of the renewal beyond the 2034 date of the leases. And then, Jeff has pocketed money in the contingency reserve for projects. We would be drawing from those reserves to fund this initial phase of work, and then hopefully all things are a go, and we can come back in 23 with the remainder of the project budget. And I am happy to answer any questions unless they were related to clinical care, and then you've got to look that way.
Thank you, guys. Thank you, John. Thank you, Stephanie, for the information. What I'd like to do is to get a motion on the table first, and then discussion afterwards. So Manager Greenberg.
I move that the board authorize project costs to advance Central Health's multi-specialty clinic services at Rosewood, Zaragoza in fiscal year 2022 in an amount not to exceed $1,143,000.
Thank you, Manager Greenberg.
I
Manager
second the
Brinson?
motion.
I have a motion from Manager Greenberg. I have a second from Manager Brinson. We're now open for discussion. Manager Brinson?
Yes, what clinics are in there now
Oh,
and where will they go?
so the site has actually been empty. So the primary care clinic, the community care operated, ceased seeing patients a number of years ago. We did look at doing some relocation of some other service lines into that for community care. Those did not seem feasible. There was a significant amount of work trying to kind of just assess the building itself. It was empty when community care approached us and they approached Mike actually during Christmas, to use it for the vaccine clinic. And that we did put some investment in initially to get the building occupiable, but it has been empty. But now, great timing. And it's a really efficiently designed space. Sometimes, some of our other clinics I wish were as efficient as this one.
Thank you. Manager Zamora?
You know my statement. Let's do the right thing for the patients.
Thank you, sir. I appreciate that. And I just want to clarify, this is a multi-specialty clinic. It's not a primary care clinic. So mainly your patients will be referred from our primary care clinics to this clinic to receive specialty care, because they will have seen a primary care doctor already and has been decided that they need a referral, they need specialty care. And this will be the site that we can send those patients to be able to receive that care. Am I correct?
Absolutely. Yes, sir.
Okay. Manager Greenberg, any questions, statements?
No, I think that this would be something that would really help us. We know that, specialty care is something that we continue to strive to make improvements in. So thank you.
Thank you. Manager Jones.
I don't know if I can pull any rabbits out of the hat over the city, but I'll be happy to talk with you. Just a couple of questions. One is, I do agree with this is a good use of this facility. And I compliment you all on going ahead and beginning to look at this in terms of the big picture of what we as a district should be doing. And so I think this is a good beginning phase to start looking at that effort. I guess my question specifically relates to location. Given what's happening in Central East Los, and I understand it is a referral clinic, so it's not a neighborhood clinic, but built into this capacity, the possibility of looking at maybe a second or another one that's down the road that we would look at, I would encourage you to do as well, using this as a model, but recognizing that we'll need to be in other areas over time. But I would be very supportive of it, and thanks so very much.
Thank you, Manager Jones. Manager Zuniga?
I was really happy to see the personnel that are listed. Central Health patients do have much improved outcomes if they have a clinical pharmacist and a case manager and a nurse. So I think that is really setting up these patients to have a lot of success in their self-management. So it's really exciting to see. And these wound care nurses are spectacular. So I think that is set up to be a really exciting and really improving the health of the patients in the area. So I'm excited about it to move forward.
Best care is delivered by a team, for sure. Thank you. Manager Musaitif.
Yes, thank you. And following up on your comments and question, Dr. Bell, I definitely, as we know, primary care is very important to connect individuals to specialty care, and especially the community that we are serving, the underserved, which their needs are greater than the clinical wall. So having that paradigm, that connectivity between the clinical specialist and the in their PCPs, it's very critical to improve their health outcomes. So what I hope to see in the future, really a paradigm shift where we're collaborating, the specialists are collaborating with their primary care physicians to overall improve the health of the patients. So not to just to leave them out there, you know, they saw a specialist, and whereas their primary care physician who's managing other diseases and is left out of the equation. So having that connectivity, that open communication, which I understand, I believe the medical, the electronic health records will have the interoperability of data, but we also need to have an open engagement between the two providers. Thank you for this initiative.
Thank you, Manager Musaiti. Manager Matwani?
Thanks. I certainly share in so much of the enthusiasm of everyone in the room. So please don't look at me as a party pooper with this question. It's that if I remember the Hornsby Bend construction line item, I think was something similar to the construction line item here. And there were a lot of unanticipated variables, inflationary ones, just all sorts of other ones during the pandemic that caused that construction line item, I think, to double or something on the order of doubling. Can y'all speak to how, I guess, this may be different and or what are sort of the considerations in place to help mitigate, I guess, any kind of inflation on that order anyway? I mean, I think we can, obviously there's a reasonable expectation and contingency is already built in, but I think you know what I'm asking. Thank you so much.
Absolutely. I do want to start with, this is a different model. This is a model that's been developed by some of the professionals that have joined our team. And so this is a different model than we used for those both Hornsby Bend and Del Valley clinics. Those clinics were priced before the pandemic. So this actually reflects some of the newer inputs that we have in materials costs, et cetera. I would like to point out the very different scale. So what we're doing here is a renovation. It's a significant renovation, and I want to be very clear about that, rather than a greenfield construction, which we were doing in Hornsby Bend. And so Hornsby Bend also comes with a lot of challenges in terms of utility connection. Much of what we had to do at the very beginning was just make sure and we understand kind of where the utilities were, because we had to not only connect to them, sometimes we had to build lines separate from what was already there. And so won't get into the details of that, but so this is nice. We know it's connected to Austin Water and Austin Energy for what it's worth, and we don't have those costs and those kind of uncertainties up front. I do think that we will come back with a much more refined picture about what the project costs are. This is a starting point so that you all have some sort of idea that this is the kind of investment that we think this will take. And like I said, I have no idea what John and Alan are cooking up in terms of the actual provision of care and what that looks like. But I think that the equipment we needed for diagnostics and cardiology and some of these other very critical specialty lines may be more than what's reflected, for example, in that FF&E line right now. So we put some placeholders in. We will definitely come back to you that, and ideally, because this is a renovation, the cost would be different than what we saw in Hornsby Bend and Del Valley.
Thank you. Thanks, Chair Bell, and please don't let my hawkish curiosity belie my admiration for a team that's managing so much complexity and so many moving parts at one time, not to mention able to distill it and share it with us in the form of that Gantt chart in a way that we can digest. It's really, really a privilege to be a part of this. Thank you.
Thank you, Manager Matwani. Manager Valadez, as you know, we've heard most of your comments in citizens communication. So again, any comments?
I'm sorry, the computer died. We lost it. There was some kind of error. But thank you. Yes, you got my comments, if I'm not mistaken. And I don't know if you got my final comments, because that's what I sent to Brianna to distribute, not the first draft. So in the final comments, basically what I'm really just asking, and I guess, John, I didn't ask this of you before, I just wanted to make sure that you have done a full assessment with Jason and the other providers, specialty providers in this area, to make sure that they don't have room for us. We're not contracting with them. And, you know, basically looking for efficiencies that can be had by the development of this site. You know, I'm the one that I was the biggest and loudest person for not closing the Rosewood Zaragoza site when it was there, and they were looking for, and Central Health was telling me, no, it needed to be closed. As they built the Anderson Clinic. But, you know, we closed it, we opened it, we closed it, we opened it. That's okay. I just want to make sure that we're efficiently spending our tax dollars, and that you have actually surveyed the specialists, and you know that this will be a perfect siting for our patients, our MAP patients, our MAP basic patients, our CHAP patients, whatever. In light of the fact that we've been going through so much displacement and gentrification in our East Austin community, you know, travel is still an issue, and have those things been addressed?
John?
Yes, sir. Thank you, Manager Valadez, and happy to work on answering some of the questions that you submitted by email as well. To answer your immediate questions, one of the things I think that you may have missed when you were trying to get logged back on was I wanted to make sure that the board understands that this is not intended to replace our partners. You know, we are still going to work with community care. We're still going to work with Ascension. We're still going to work with Dell Medical School and the many other specialty care providers that we contract with and partner with in the community. The conversations are not done, but those are ongoing. So we are engaged in conversation with Jason, with Dr. Yagoda, with Dr. Dubois, their specialty care director at Community Care, and they are providing input every step of the way. They're walking the facility with Dr. Shalsha, and we are working with specialty care subject matter experts in each of these specialties to design the program, to identify the appropriate diagnostics, to plan out the actual provision of care. One of the unique things that this provides us when we actually right-size the service is we can move away from just face-to-face office visits. So part of adding multiple additional full-time equivalent positions is we can redesign to a large extent how we program that time. That's also what a employed model, not a contracted model, allows us to move forward with. So we can spend time on referral management. We can spend time on e-consults. We can emphasize quality engagement with patients versus just getting in front of more patients. So that may mean longer but more effective visits. You know, we are building in time for diagnostics and for the professional reading of those diagnostics, and we will build in time for procedures that happen in this clinic and that happen in surgery centers or potentially in the hospital as well. So you know, having this type of model allows us to fine tune those different aspects.
And John, just to add on to that, if I may, real quickly,
Yes,
you know, having a few spare rooms here and there in different facilities around town, you lose that efficiency that John has outlined that you have by having it at centralized locations, but then realizing, to Manager Jones's point, you know, there are other future locations that we'll need to look to expanding to the similar model. Thank you.
Thank you, Mr. Giesler.
If I can just finish the last part about transportation and access, it is actually in a very unique location, and the Senior Citizen Center is immediately behind it. We have seen ACC Eastview is kind of catty corner. LifeWorks is across the street as well. So there's a lot of metro access as well. We know that from the vaccine work that we were able to reach a lot of folks from many different areas, and it was considerably more accessible than we may have realized.
Thank you. All right. I have a motion from Manager Greenberg to call the question. Any objections? Then all those in favor of the motion on the table, say aye.
Aye.
Any opposed? Any abstaining? I have one abstaining, Manager Valadez.
And I look forward to the responses, John. Thank you. And
Thank
Stephanie.
you. Thank you. Motion carries. Agenda item number 5, confirm the next regular board meeting, date, time, and location. Managers, our next Central Health Board of Managers meeting is scheduled for Wednesday, April 27th, 2022, at 5 p.m. at AISD headquarters, 4000 South I-35 Frontage Road, Austin, Texas, 78704. At this time, I'm ready to accept a motion for adjournment.
I move adjournment.
I have a motion from Manager Greenberg. I have a second from Manager Jones. All in favor?
Aye.
Any opposed? Any abstaining? We are adjourned. Thank you, members. I appreciate it.